Good evening. Welcome to the Iridex Cyclo G6 MicroPulse webinar. My name is Kevin LaMarche, and I will be the moderator for tonight's webinar. The webinar will cover the basic surgical technique of MicroPulse, and then we will explore a number of case presentations offered by Dr. Brian Francis. We're honored to have Dr. Francis here tonight, who is the Rupert and Gertrude Steiger Endowed Chair in Vision Research, Professor of Clinical Ophthalmology, and Director of the Glaucoma Service at the Dehaney Eye Institute, University of California, Los Angeles. The technique for MicroPulse Transscleral Laser Therapy is a power setting of 2,000 milliwatts, a treatment duration, if you're doing hemispheric approach, 80 seconds per hemisphere, or if you're utilizing a quadrant approach, it's 40 seconds per quadrant. The dwell time, or the time it takes to sweep back and forth, or one sweep, is 20 seconds per hemisphere for a hemisphere approach and 10 seconds per quadrant approach. The duty cycle should always remain at 31.3%. And again, MicroPulse is not a discrete single spot application. This is a sweeping motion along the limbal margin, both superiorly and inferiorly. And it's important to note that we spare the 3 and 9 o'clock positions so that we're not treating over the ciliary artery and nerve. So as I said, there is a technique to this procedure. And so we have orientation of the probe, again, flat side toward the lids, round side toward the limbus. We place the outer edge of the notch on the surgical limbus. And it's important to understand the parallax of the probe, that you might have to lean over a little bit to look directly down the handpiece to ensure that you're not sitting too proper on the limbus and that you're actually on the surgical limbus, not over the limbus. Make sure the probe is in a viscous liquid interface. And by that, we mean either a gonioscopy fluid, or if you need a sterile agent, you can use single-use sterile lidocaine gel. Both are very well tolerated and actually work very well with the probe. As we aim the probe, the orientation should be towards the center of the globe. So we're aiming towards the center of the globe. And we need to apply adequate pressure. Contact laser delivery is based on coupling and pressure. So pressure, by what we mean, is like a pen to a piece of paper. So it's not heavy indentation, but light enough pressure so that you do have engagement and coupling with the tissue. 4 to 5 passes per duration is what we're looking for. If you're doing hemispheres, 20 seconds, it's going to be 4 passes. And if you're doing quadrants, at 40 seconds per quadrant and 10-second passes, again, 4 passes. It's critical that you ensure you have adequate exposure. So before you start, it's advisable to take a practice sweep, both superiorly and inferiorly, so that you can make sure you're not going to run into any trouble, you have adequate exposure, and there are not any limitations as you're doing the procedure. It's better to find out before you start than you're actually doing the procedure, then realize you might have an exposure problem. And it's very important to be comfortable during the delivery of the treatment. This will ensure that you can concentrate on the technique points while maintaining the desired efficacy and limiting any kinds of complications. So again, back to the technique point. It's a must to use the liquid interface, viscous liquid interface. That will ensure that you're getting all the energy possible instead of starting with almost a 50% reduction before you even get going. Make sure we orient the flat side towards the lids and the round side toward the limbus. Place the outer edge of the notch on the surgical limbus while treating, and we should be aiming towards the center of the globe. And again, adequate pressure like a pen to paper. Whether you do hemispheres or quadrants, it's more so what makes you more comfortable that's important as opposed to which approach you take. Both of them deliver excellent results and really don't, implicate any influence on efficacy. But if you're comfortable, you can then concentrate on the technique points that you must maintain. And again, 2,000 milliwatts, 80 seconds for hemisphere, 40 seconds for quadrants. If you're not doing these technique points, these are some of the things that can actually, influence the amount of efficacy you get, as well as complications. Without the liquid interface, you're going to lose a great deal of energy, so you may have a less durable, less efficacious treatment. If the probe orientation is incorrect, that moves the fiber closer to the limbus and can enhance any types of complications that you could run into. It's also very important to make sure we're not riding up on the cornea, because you have limbal stem cells as well as the corneal nerve that you could be directing energy towards if you're too close to the cornea. So we want to stay away from that. And the angle of the probe should be towards the center of the eye, which keeps the energy focused on the ciliary body. And again, we must have some pressure. We need to couple with that tissue with the liquid interface and the pressure to ensure that we're getting the most possible energy transfer. And again, both hemispheres and quadrant approach work wonderfully. It's just how comfortable you are and which allows you to maintain better technique. And again, it's also, we need to remember that MicroPulse can be used prior to, in conjunction, and following any current glaucoma therapy or procedure, which makes it very unique in the paradigm of treating glaucoma, as it can be introduced at different spots in the patient's lifetime of their glaucoma. Okay, I'm now going to hand over control of the slide deck to Dr. Brian Francis. And Dr. Francis, it is all yours.
All right, thank you very much, Kevin, for that introduction and telling us a little bit about the specifics of how to do the laser. What I'm going to talk about tonight is basically how I use MicroPulse cyclophotocoagulation in the treatment of glaucoma in my practice, and we're going to go over some data from our study as well as some case presentations, and then we'll leave ample time at the end for question and answer session. So as an introductory slide, basically there's 4 mechanisms of action that we use to lower IOP surgically. One is transconjunctival filtration, such as you see with trabeculectomy or Zen implant. One is aqueous inflow, which of course we're talking about that with cyclophotocoagulation. And then there's trabecular outflow, which is the majority of our MIGS angle-based techniques, such as iStent. And then finally, suprachoroidal outflow, which is not currently available, but will be likely available in the near future. So we don't have to go over all of these procedures, but right now, as far as inflow procedures, there's 3 examples: ECP or endoscopic cyclophotocoagulation, your traditional transscleral cyclophotocoagulation, and now MicroPulse CPC. And here we have a list of outflow procedures, both subconjunctival filtration, trabecular approaches to the angle, and uveitis outflow. Interestingly, the mechanism of action of MicroPulse CPC is thought to be reduction of aqueous inflow, but there is some data that suggests that there may be other mechanisms of action, including trabecular outflow and uveitis outflow. So that remains to be seen. I won't belabor this slide because Kevin has given us a good background on that. We'll get straight into some data. So basically, this is a paper that is just coming out in ophthalmology glaucoma, and it's our practice and how we saw our results in terms of treatment of refractory glaucoma with the MicroPulse cyclophotocoagulation. So the design of the study was a prospective interventional case series of patients starting from August 2016 up until the end of 2018. The laser settings were 2,000 milliwatts and 31.3% duty cycle, and the duration ranged from 90 to 140 seconds for each hemisphere, so a little bit more aggressive than Kevin was discussing, but I've really scaled back in my practice to about 90 to 80 per hemisphere, as Kevin had discussed. Outcomes were, of course, intraocular pressure, but also visual acuity. We checked for complications such as anterior chamber inflammation post-operatively. So we had approximately 100 patients, so with 104 eyes, with mean follow-up period of 118 days. Visual acuity was equal or better than the pre-operative in over 60 patients, 60% of patients, and 40 patients decreased vision by an average of 1.6 lines of vision over the course of the study. This is a little slide which I want to show you first the baseline IOP. Here it's in the low 20s, 22.2. And then at final post-operative follow-up at average of about 1 year, you have a reduction to the mid-teens, 15.6%. And the vision, as you see, is slightly decreased overall, but basically unchanged and not statistically significant in terms of difference. And then finally, you have glaucoma medications as well, which did show a decrease over time from an average of 3.1 to an average of 2.7, which was statistically significant. This is another way of looking at the pressure curve. So here we have baseline IOP of about a little over 22 and down to your 6-month period in the mid-teens. And it shows you the pressure at different time intervals. At all time intervals, it was a statistically significant reduction of pressure from the baseline. And another way of looking at it is the amount of reduction from baseline. So here we have at the different time points, all the way out to month 12, you have the millimeters of mercury of reduction from baseline. And if you look out to month 12, you're looking at about 9.8 millimeters of mercury reduction from baseline. So very significant reduction. And then we looked at the survival curve, basically the ability to control pressure by reducing the pressure 20% or greater from baseline and having the pressure below 21 and not having any additional surgeries or glaucoma procedures or glaucoma medications. And this is the overall group. At 12 months, it's approximately 60%. But we did a sub-analysis where we broke down the survival analysis based on their surgical history. So what you see here, the red line represents patients that have had prior traditional glaucoma filtration surgery. So that's not MIGS, but that's your trabeculectomy or tube shunt. And we took that group and compared them to the group that had not had prior traditional surgery. You see that the success rate is better, statistically significantly better in those patients that have had prior traditional surgery. Complications are relatively minor. We have approximately 30% with mild inflammation on post-operative day 1. 2 patients of those had prolonged inflammation that resolved within 60 days. 2 patients developed hypotony and choroidals within the first post-operative month, which resolved within the 30 days. And 1 patient had initially a very high pressure post-op day 1, but then that resolved, and actually they had hypotony for a couple of weeks. And I'll make a statement about the complications. I've done a lot of transscleral cyclophotocoagulation prior to MicroPulse and also ECP, and I was very surprised when I started doing MicroPulse with how little inflammation that you actually get. So that was, again, quite a surprise and a pleasant surprise. I have here some, when we're speaking about complications, the best way to treat complications is to avoid them. And I think here's some surgical pearls on how to reduce your complications. Start with treatment with lower power application, as Kevin said, 80. It's the 80-2000 and 31.3% rule. That's 80 seconds per hemisphere and 2,000 milliwatts, and the duty cycle at 31.3%. Avoid treating the 3 and 9 o'clock clock hours. This reduces pupillary function abnormality afterwards and reduces postoperative pain. Treat with a coupling solution. My favorite is lidocaine gel because it both gives some anesthesia and gives you an ideal coupling solution for the laser to take effect. And many of these patients have had prior trabeculectomy or tube shunt surgery, so be careful when bringing the probe over those areas that you don't tear the conjunctiva or cause a hole in the bleb or something like that if you're pressing too hard. While the probe should be lined up at the limbus, it should not overlap the limbus. So I like to actually see a little bit of white at the limbus between my probe and the cornea. And, finally, any complications that you do get, hypotony, inflammation, decreased vision, and pupil abnormalities do resolve with time. Okay, here's a list of quick references. So let's move on to some case presentations. The first one was a fairly complex patient. He was a member of our trial that we just reported. He's a 53-year-old Asian male with severe primary open-angle glaucoma. He's monocular due to having eye trauma in his fellow eye while he was living in Vietnam. His vision is 20/25 in his only eye. His surgical history is positive for trabectome in 2008, which controlled his pressure for approximately 6 years, at which point he then had a barbell 350 tube shunt in 2014. And since then, the pressure has been reasonably well controlled, but then recently, prior to the procedure, went up into the high teens, low 20s on 3 medications, the prostaglandin, a beta blocker, and an alpha agonist. And you see how he had a cup-to-disc ratio of 0.95. So very significant glaucoma in monocular patient. So in this monocular patient, you obviously want to do, what's effective, but also what's very safe. We discussed his options with the patient, which basically include placing another tube shunt, doing an ECP, or doing the MicroPulse. And we ended up, as you see in the photograph here, of doing a MicroPulse cyclophotocoagulation. So here's his postoperative course. He did become hypotenuse in the first 4 to 6 weeks, and his vision initially decreased to 2200 with choroidal effusion. And this is personally the only patient I've ever seen with a choroidal effusion after the procedure. However, he did maintain a formed and quiet anterior chamber throughout this postoperative period. We treated him with steroids and atropine drops, decreasing his glaucoma medication. His IOP gradually increased into the 9 to 13 range, whereas it has remained in the low teens with vision recovering to 20/25 on a single medication, alpha agonist. Okay, case number 2 is a 65-year-old Caucasian male who happens to be a practicing ophthalmologist, has severe primary open-angle glaucoma, and again, monocular due to vision loss from central retinal vein occlusion in his fellow eye. His vision in the eye that we're treating is 20/30, so good vision. He's had laser trabeculoplasty, and his pressure now is in the high teens on 4 medications, prostaglandin, beta blocker, alpha agonist, and an oral carbonic anhydrase inhibitor. And cup-to-disc ratio is 0.9 to 0.95. So we're discussing with this patient his options, and really we want a target pressure of 10 to 12, maybe 13 at the highest, so the low teens in this patient with advanced glaucoma. And options, then implant is one, trabeculectomy, tube shunt, and we also discussed a combined procedure. So in order to try to get his pressure as low as possible, we discussed doing a MIGS angle-based procedure, which you can see here with the trabectome, in addition to having a MicroPulse cycle of photocoagulation at the same time to try to really bring him down to that target IOP level without doing a filtration surgery. So here's his postoperative course. At 6 months now, the pressure is in the 10 to 12 range. The vision decreased initially to 20/50 due to cataract, but returned to 20/20 with the cataract extraction. Now the patient is still on a prostaglandin beta blocker alpha agonist, but is no longer on the oral carbonic anhydrase inhibitor. It is on a topical CAI, and was able to avoid filtration surgery, which was very important to this patient who, as I said, is a practicing ophthalmologist and wanted to avoid a filter if possible. So I wanted to switch gears a little bit and talk about my experience with MicroPulse in a study that we're doing in Mexico. And because of its good safety record and decreased complications, we wanted to study it in a patient population of more mild glaucoma. And we did this as part of a medical eye mission that we do in El Fuerte, Mexico. For those of you not familiar, El Fuerte is about 500 miles south of the Arizona-Mexican border, and it's in the state of Sinaloa. Here is an example of the waiting room. Patients come from miles and miles around to get care at this free clinic. We screen them. On the left, that's actually my son, who I brought with me to the clinic on the mission. And to the right, you see the combined operating room with 4 tables with surgeons operating away. And this next case I want to present is a patient from that experience. So we have a 75-year-old Latino male with severe POAG. Vision was 20/70. IOP was 23 on a prostaglandin and a beta blocker. And the cup-to-dis ratio was 0.9. And the problem was that the patient had difficulty obtaining the medications. And so when they took the medications, the pressure would come down, but again, difficulty obtaining medications in that area. So we decided to do the MicroPulse, and here you see his postoperative course at postop day 1. The pressure was 13 at 6 months. Follow-up was 12. At that point, we were able to discontinue their timolol, and at 12 months, the pressure was 11 on the travotan alone. And the visual acuity at 12 months was 20/80, so at the baseline. So in conclusion, I'd like to make a couple of statements. I think that MicroPulse cyclophotocoagulation is a non-invasive glaucoma surgery with multiple potential mechanisms of action. We talked about aqueous reduction. We talked about possible uveitis scleral outflow as well as possible increased trabecular outflow. It's applicable really in all types of glaucoma. So you can do it in primary open-angle glaucoma, secondary open-angle, chronic angle closure glaucoma, even neovascular glaucoma. It can be combined with other surgeries such as MIGS, doing them concurrently, like you saw in our second patient there where we did a trabectome and a MicroPulse. Or it can be combined sequentially with other surgeries. So as you saw in some of our other patients who had had a prior failed tube shunt, for example, you can do this afterwards. You can also do it as the first surgery, as you saw in the last patient from Mexico there, had never had any other types of glaucoma surgery, and it was very effective. So really, it can be used kind of at any time in the treatment spectrum, and also can be used in almost every type of glaucoma. There's a low risk of complications. It's repeatable and to some extent titratable. And it, again, additive to almost any other type of glaucoma surgical procedure. And as we saw from our trial that published in Ophthalmology Glaucoma, it works especially well in the setting of prior filtration surgery. And due to its safety profile, I do feel safe in using it earlier in the treatment paradigm and even as primary treatment, as you saw in that patient in Mexico, to try to get them off of their topical medications. Okay, so that's the slide presentation, but I'd really like to open up to the questions via the chat. I think we have Kevin. Do you have? Let's see. Let me open the questions Q&A. Here we go. So if you'd like, everyone, we can type questions into the chat box here. There's a Q&A. The first one is, what are the contraindications for using this technology in patients with glaucoma? Really, there's no contraindications besides just physically being able to do the procedure. So I think if if a patient has extremely tight lids or a tarsorrhaphy or some issue where you physically cannot get the probe in the desired location, then that would be a contraindication. Interestingly, uveitis and uveitic glaucoma you'd think would be a contraindication to doing this, but I've found that it's not. I've actually done this procedure in patients with PKH-related uveitic glaucoma, and the eye was actually very quiet from post-operative day 1 on. So I think that's not really a contraindication in my mind. Next question. Okay, what is your post-surgery management? So that's a great question. What I do typically is I keep the patients on all of their glaucoma medications until post-operative day 1 or post-operative week 1, whenever I see them. And I start topical steroids and topical NSAIDs. So typically, prednisolone, we start it at 4 times a day, and the NSAID 3 times a day. And over the course of 2 to 3 weeks, we're able to taper them completely off of their steroids and nonsteroidals. And then again, as I see them going forward from the post-operative day 1 visit, I will stop their glaucoma medications depending on how well their pressure is controlled. So, okay, so one more question here. Does this get IOPs into the 12 range if they start in the high 30s? That's a good question. We actually don't have that information in terms of studies, but I have seen anecdotally patients that have started with very high IOPs and can get into the low to mid-teens. Typically, those are patients that have another type of surgery already. So patients that have had, for instance, a tube shunt in the past, or some sort of glaucoma procedure in the past, and we do this and they do get down. If I had a patient that was in the high 30s and had never had glaucoma surgery before, then I might, and I wanted to avoid filtration procedure, I probably would go with the example that we saw where I combine it with a MIGS, an angle-based MIGS procedure to try to really get that pressure into the low teen range.
There are also some questions, Brian, on the webinar chat too that I can read to you and get your answers to that. Okay. We have one question asking, are you using a total energy of 50 joules only? And I can answer that one for you. No, that would be a no. 90 seconds gives you about 112 joules of total energy, so it would be a little bit more than 50 joules for the total treatment. Even if you were doing 80 seconds, that's just about 100 joules even. So he's doing about twice the 50 joules that you're asking. Second question is a patient with neovascular glaucoma without vision, and they'd like to know if they can use MicroPulse in that case where the IOP is 50 millimeters of mercury in a painful eye.
Right, so that's a good question. I think for treating a blind eye with neovascular glaucoma, I think it's important to make sure that the patient is, it understands obviously what the risks are, and that you're treating them as a palliative measure, trying to relieve their pressure and relieve their pain, usually from just the high pressure or from corneal problems due to corneal edema. I think it is a reasonable procedure. It's non-invasive, so I think it decreases their risk compared to tube shunt, which would be my other go-to for neovascular glaucoma. I think even if it reduces the pressure into the 30s, it can have a significant improvement of their symptoms, of their signs and symptoms. So yes, I do think it is a viable treatment option, even in neovascular patients with no light perception vision and high pressure.
So a next question is, in patients with prior BGI 350 or 250s, have you found the MicroPulse equivalent to ECP as a second procedure for additional IOP lowering? And if so, do you treat both hemispheres always?
So we published a paper years ago on ECP after tube shunts, and we found it to be quite effective. And also we made a comparison of that versus a second tube and found it to be equally effective. And we haven't compared them directly, but it's my opinion that that MicroPulse after tube is equally effective and actually has less complications, less inflammation, et cetera. So that's kind of become my go-to procedure after a failed tube shunt. I have another question here in the Q&A box. Do you want me to go through the Q&A box questions as well?
Yep.
Okay, so here's one. When do you consider retreating? Have you retreated patients in your study? So the answer to the first question is I would wait until, so unlike other procedures, this is actually repeatable and titratable. So for instance, if you treat a patient and 3 months later you're not happy with the pressure, they maybe had some pressure lowering but not as much as you'd like, you can repeat the procedure and get more pressure lowering. So I would wait at least usually about 3 months, calm the eye down, get them off the steroids, and make sure everything is kind of reached equilibrium state, and then you can consider retreating after that. In our study, we did not include any retreated patients, so that was these are all just the primary treatment. We have another question. Had one case of macular edema, even though the pressure was never below 10. I don't know if that's a question or a statement, but certainly there's a potential for macular edema with hypotony. There's a potential for macular edema without hypotony, just from the fact of having surgery, even though it's laser surgery. Just like any surgery, you can have cystoid macular edema afterwards.
One comment on the macular edema, and I don't know, Brian, if you perform this, but we do suggest getting a macular OCT prior to the treatment, just to establish baseline, so that the surprise that you may run into could have been something that was actually treatable prior to the laser application. Yeah, that's true. That's true. Have you used this patient with silicone oil where the oil needs to stay in because of RD? Yes, actually, it's a very good treatment where there's silicone oil in the eye, and for example, you don't necessarily want to do a tube shunt because the oil may come to the front of the eye and come out the tube. So yeah, it's a very nice procedure because the eye stays in a closed state. And it's definitely usable in patients with silicone oil glaucoma. Okay, so go ahead. Yeah, one question here was, how do you manage patient comfort during and after the procedure? So that's a great question. I initially started doing retrobulbar and then giving the patient, propofol with an anesthesiologist. And we got away from doing the retrobulbar. We found that it didn't really matter that much. However, the retrobulbar or a peribulbar may help with post-operative pain. But typically what I do now is I do the patients in the surgical center. We have anesthesia to give them propofol, just basically like you're doing a retrobulbar block.
but the patient's asleep for 5 minutes. You do the procedure, and they wake up and go to recovery. Post-operative pain management. Typically, most patients will need very little. There are some patients that have significant pain after the procedure, and what we do for those patients, it depends on the anesthesiologist, but usually we'll give them Toradol IV for kind of longer-term pain management. And then you may give, depending on their pain level, you can give them a narcotic in the recovery room. But we found overwhelmingly, I mean, even if they have pain in the immediate postoperative period, that's usually gone by the evening, and the next day the patient, is very comfortable.
Do you routinely cycloplegia your patients?
No, I haven't found the need to cycloplegia them. I will cycloplegia them postoperatively if they have significant inflammation or pain, or if they have a choroidal effusion, but those are rare cases.
And then one last question from this chat. Any increased risk of cataract formation?
That's a good question. I think certainly the answer, I'd say the answer is we have not shown that there is. So there's no studies that have shown that there's an increased risk of cataract formation. But I think any surgery in the eye, even a laser where you're just delivering laser energy into the eye, will give you some risk of increased cataract formation. So, I'd say the answer is probably yes, but we don't have the data, to really know what that risk is, how high that risk is.
Okay. One other question, is MicroPulse additive to SLT?
Yeah, absolutely. I mean, they're completely different mechanisms, and they're, although both lasers, they're kind of on different spectrums as far as the treatment algorithm. I think SLT is basically akin to medical therapy, whereas the MicroPulse is a much more effective IOP lowering tool, and so in many ways is more aggressive and can be used in cases where SLT is just not adequate.
Very good. That takes care of all Zoom.
Okay, I had another question in the Q&A session here. Oh, actually, we have a few. Okay, so one surgeon's worried about sympathetic ophthalmia in the other eye. Is this a real concern? I think, yeah, I think it's not a real concern. I don't think it's ever been reported. If the eye that you're treating is normal or fairly normal. They did say it was a preticical eye, so I'm not sure I would be treating a preticical eye. Usually those eyes, the pressure is quite low. But I've not seen or heard anything in the literature about sympathetic ophthalmia in the fellow eye. Next question, do you recommend it in secondary glaucoma in a large axial length? Great question. It's actually a great procedure for someone with high myopia and long eyes. Certainly, we know that traditional filtration surgery can be fraught with complications in highly myopic patients. They're more prone to hypotony-related complications with hypotony maculopathy, even at normal pressures, because the eye is just not, the support structure is just not there. So I think it's a great procedure, in long axial length eyes. Okay. I have a question, where are you? So I'm at Doheny UCLA right now. I'm in our Pasadena office in California. And then last question here right now. How many times have you treated the patient with MicroPulse before you moved to incisional surgery? So that's a great question. I mean, we did talk about how it's repeatable and titratable. In my practice, generally, I will, so it depends on what you're talking about. So I'll give you two scenarios. The first scenario is a patient where you do the procedure and you get basically no pressure lowering. I would still repeat it in that patient, and then if after 2 sessions you've gotten very little pressure lowering, I would move on to an incisional surgery. If it's, however, a patient where you treat them once and their pressure comes down 10%, but you want it down further than that, you can treat them again. And I think you can keep treating them, 3 to 4 times as kind of a titratable pressure lowering treatment. So, I'm not sure there's a hard answer in those patients, as long as they do get incremental pressure lowering with each procedure. Obviously, you're going to reach a point where, it's going to be, untenable to keep doing multiple procedures. But I think, in those kind of patients, you could argue for doing it more than twice before you go to an incisional surgery.
First off, I'd like to thank Dr. Brian Francis for sharing his time and his expertise and wealth of knowledge about MicroPulse with us this evening. Thank you for joining us today, and have a wonderful evening. Thank you, Brian.
Wonderful. Thank you.
Okay. Good night, all.